Uh, Welcome, everybody. I am Jenny Peck. I am on the individual fundraising team here in the Amref USA office. I'm really excited that all of you guys can make it here for this interactive supporter call around Mpox. So as I'm sure we've all have heard, the WHO has recently declared the Mpox outbreak in Africa as a public health emergency of international concern. So we're so grateful that you're all here, joining us from the US, the UK, from across Africa for this very timely conversation. So over this next hour, we will have our staff members from Amref speaking about the current state of the Mpox crisis, the challenges that it poses, and how Amref is working to raise awareness and curb the spread of Mpox. So our speakers will talk for about 40 minutes, and then we will open it up to you all at the end so we can ask questions. So for questions, feel free at any time to put them in the Zoom, and we will answer those at the end of the conversation. Also, we would love to hear from you directly. So if you would like to, at the end, unmute yourself, raise your hand, ask a question directly to the speakers, feel free to do that as well. Let me introduce to you today a few of our wonderful colleagues. We're here today with Boniface Hlabano. Boniface, do you want to give a wave? Can you wave to everybody? Yes, there's Boniface. Boniface is the head of our Global Health Security Unit at Amref, and he is based in South Africa. And we're also joined by Mary Mathenge. Mary, are you here? I haven't seen Mary. Hopefully she... Okay, well, we will be joined by Mary. She is the Public Health Security Program Project Manager at Amref Health Africa, based in Kenya. So Mary leads many of our biggest health security initiatives in Kenya, and Boniface is doing the same for multi-country programs across the region and partnering with agencies like the African Union. So finally, it is my pleasure to introduce you to Amref USA's CEO, who will be our moderator today, Bob Kelty. Bob, I'm going to pass it over to you.
Okay. Should we? Okay, I guess we'll get started without Mary. Well, it's a real pleasure to have everyone join us. I think we're gonna have a really interesting conversation about Mpox. Just looking through what, especially in the US, Canada, the UK, and in Europe, I think there's a lot of confusion about what Mpox is, how it's transmitted, the risk involved. And so I think it's a really timely time to have this conversation. And I think Boniface and Mary will be going into why it's important to act now and to really, make the investment now before it spreads. And, when we talk about health security, we're all interconnected here, whether it's, and so it's an important time to meet it at its root. I think it's also a really interesting time. This is been out with Amref for 10 years, and this is the third health emergency I've gone through. And the first was in 2014 with Ebola. And there's a real difference. In 2014, the African continent had no say about how resources were going to be distributed, what kind of, what the intervention was, no say in the strategy. And I think came out of that was the African Union. There's Mary. Hi, Mary. Just wave.
Hello, Bob. Sorry for getting in late. I had some technical hitches.
No worries, no worries. We're just glad you're here. And we saw during COVID, there was this first shift. And I think out of Ebola, the realization by the African Union was that they needed to create a health arm for their organization. And that's when the Africa CDC was created. And Amref was very involved in the creation of the Africa CDC. And we have an incredibly close partnership with them. And we are their largest technical implementer on the continent and strategic partner. And we saw in COVID that there was a real donors understood that the strategy and the investment needed to be through Africa, and that I think the prominence of African NGOs really rose. And we saw vaccine injustice going on. So I think there's been a voice. And what I think Jenny touched on briefly, the WHO is called a health emergency. And also for the first time ever, the Africa CDC has called a health emergency too. And very much taking the lead on responding to Mpox. And so I think with that background, I think we've seen in the North, in the UK, in the US, some preparations going on strategically looking at vaccines. Mpox, I won't go into technical stuff. I'll leave Boniface and Mary to do that. So there has been some shifting and looking at vaccines and purpose and preparation. So hopefully there'll be a little more preparation than there was in the past. But hopefully, the work we do in Africa will slow this down. Boniface and I have worked together for probably 8 years. We worked very closely during COVID. He has great insights of what's going on and constant conversations, both in the communities across Africa, but also with the leadership of governments in the African Union. So I found out that I just talked to Boniface like a week ago about Mpox, and I found out what I've been reading in the paper, the information I get is very different than what's going on the ground and how it's transmitted. So, Boniface, if you could just talk a little bit about Mpox, kind of the driving factors of transmission, a little bit how it's changed. I mean, Mpox has been around for 40 years or so, but just the changes, and I think really giving people some background on it so they understand the transmission.
Thanks, Bob.
Okay.
And really,
Everyone mute themselves.
Yeah.
Thank you. Sorry, Boniface.
Okay. Thanks, Bob, and really grateful for this opportunity to interface with our supporters and the generous introduction. Briefly, I always start such conversations by reminding people that Mpox first case, really, which was monkeypox, was first discovered in Belgium in 1958. This was through a lab scenario where there was an assignment to investigate some of these zoonotic diseases, but in human beings, it was first diagnosed in DR Congo in Central Africa in 1970. So it has been over 40 years of this virus, which is really caused by a virus known as monkeypox virus. Traditionally, it's zoonotic in nature, meaning that it sort of hibernates or it's carried through animals, but then infecting people through contamination or contact with infected animals, their products like blood, skin, meat, and so forth. And over the years, traditionally, really historically, that's what Mpox has been. But of late, we are seeing it sort of mutating. And this has led to then a setup where we now have what we call clades. Clades are just really like the categorization of the virus. And as I say, traditionally, we have known what is called and what is known as clade 2, which largely has been transmitted through animals, as I said. But of late, we have seen another strain, which is now known as clade 1, going further to be broken into clade 1A and 1B. The most critical aspect of this is that we see clade 1 largely being transmitted from human to human. In other words, really through social networks, sexual networks. And again, the other parameter is that it tends to cause more severe illness than clade 2. When it comes to spread, we know it's either you get into contact with infected products from animals, as I said, blood, skin, meat, but now through humans, we know again, it's getting into contact with somebody or their materials such as clothing, bed linen, fabrics, or other surfaces. If they have not been disinfected, then if through that contact, you can get Mpox. And when it comes to how it enters our body, it enters mainly through the respiratory tract. That is through our nose, our mouth, the broken skin, what is known as lesions, but also through getting into contact with blood, urine, saliva, semen, vaginal secretions, breast milk, even the mucous membrane itself, that is through the eyes, nose, and ears. And what's again emerging, particularly as we track this current strain, we are seeing it, the large part of transmission happening among sexual networks. And this does not really just limited to men who have sex with men, but even through heterosexual partners. Then the question becomes to say, given these basics about Mpox, how do we control the spread? And it's very simple. The spread is really controlled largely by avoiding contact with infected people or animals, especially those animals that are found sick or dead, but also people who present with the symptoms of Mpox. So this can be done very easily by ensuring that it's protective. It's particularly for healthcare workers and those caregivers who are nursing or looking after the patients. The use of protective personal equipment is very critical. Avoiding sharing things like bedding, towels, utensils with sick people, ensuring that most food, particularly meat and milk products, are cooked or boiled sufficiently, ensuring basic personal hygiene as we did with COVID and other things, washing our hands, our faces, our bodies with soap. And in some cases, we have found that even ash, just adding ash to our bath water in those circumstances also tends to neutralize the virility of the disease. And again, then we have to isolate patients either at home or in the hospitals. And finally, just to summarize then, because the next question could be about treatment. Currently, we know that largely treatment is through what we call therapeutics. And mostly these are like the common treatments for smallpox. But we know that like the one called tecovirimat is being used to sort of manage the symptoms for Mpox patients. But again, it's important to point out that the virus is self-limiting in most cases, and usually it will wear off in 2 to 4 weeks. But again, clinical care is quite critical to alleviate symptoms, managing pain, complications, and this is done largely through proper skin care, getting rest, use of painkillers, and staying well hydrated. And finally, just to point out that the fatality rate, that is the death among identified cases, is reasonably low, but of course we know one death is one too many, but normally it's less than 5%, and we know currently the fatality rate on average stands at around 2.7%. But we have seen again that the severity of infection, severe illness and death is again so much amongst people who have other underlying medical conditions, HIV, infection, TB, malnutrition, children, pregnant women, and largely children under 15. So in brief, Bob, I could say this is what I could share just as a start off in terms of the simple basics. Thank you.
Thank you so much for doing that technical thing. I think, I think there's a lot of information there, and I think it was really helpful to, start off with the technical, but maybe go a little bit, more specific on where, kind of the central areas of, where it's spreading, how it's affecting communities, how it could affect, communities outside of Africa. If you could go there and set the table for that. Thank you.
Thanks, Bob, again. I would like to share that in 2022, the World Health Organization again had to declare Mpox as a public health emergency of concern, of international concern, because there was outbreak, and this time it really was so much, even including beyond Africa, in most Europe, and I guess even in the United States and Canada. But then we can then say confirmed cases at this point globally. We know that there are about 110,000 to date. Again, this is a very conservative number that should be taken with a bit of caution, because I'll explain later why these numbers are sort of, these are official figures, but the estimate could be higher than this. And we have seen that since the beginning of this year in 2024, about 8,600 cases have been confirmed in Africa alone. And the epicenter really being, again, the Democratic Republic of Congo, Burundi, Central African Republic, and other countries, and 15 of them, but also including even South Africa here in the south. And we know that almost on a day-by-day cases are spreading across the continent and even beyond. But we know, I think it's important for this audience to know that currently really the majority of cases are in DR Congo, and we know that currently about almost 91% of the Mpox cases globally are in the Democratic Republic of Congo, followed by Burundi and Nigeria, and also other countries coming on board. Now, as I said earlier on, one of the really issues we are battling with when it comes to control and about the spread, the patterns, the spread of pattern, is this whole issue of very, very limited, or I can say weak surveillance that is going on in our countries. Unless people show up maybe with clinical symptoms, we are not actively surveilling carrying out surveillance for Mpox. But even when cases do show up or they're identified, there are limitations with testing, laboratory testing to confirm. I will give an example. For example, in DR Congo alone, which is the epicenter, this year, actually in the last 8 weeks, that is between July and to date, there have been almost 12,500 suspected cases. But out of all these, only 9% eventually went to be tested and confirmed. And this is about 1,100 or 1,100 confirmed cases, which gives us a testing capacity of 9%. So given this limitation, then one says the figures we are working with could be grossly underestimated. But again, we can't pronounce them because they have to pass through the rigorous test of what should be reported as a case. But again, we are seeing, as I said, that the Mpox is coming to, like any other pandemic, really, to really affect communities in different forms. The healthcare systems are getting strained. We are seeing lots of fear in communities, but coupled with stigma, which tends again to drive people underground. There's a lot of mistrust amongst communities, and we know that livelihoods are being disrupted, and so social and economic relations, even mental issues are really coming out largely to be issues of concern. Bob.
Yeah, just let's maybe dig in a little bit more into the data, because you hear 8,000 people, and you go, okay, how is this really going to spread and affect other countries? But I think a really important point, and I've read it in the Lancet, is the lack of testing. When you talk about the DRC, how many people have actually been testing? I know there's been issues with contamination when there actually are testing, false negatives, false positives, so the whole system. But any thoughts on data on how many people have actually been tested in the DRC?
The official number is less than 20,000, just there and about. We have really, I beg your pardon?
20,000 have been tested.
Yes, tested. But if you look at the suspected cases, they are over 100,000. If we're looking at the people who are working on the ground from our partners, even from Africa CDC sources, we know that the suspected cases are quite large. And remember, these are only those that have been identified or have been really voluntarily shown up. Mm-hmm. So that gives us a testing capacity really of, as I said, less than 10%. And this is just not for DR Congo, but most of our low and middle income countries. The issue of laboratory case confirmation is quite compromised. And this is why even both WHO and Africa CDC have flagged out the need to support diagnostic capacity and strengthening is one of the key pillars in the response. Bob.
Yeah, I think we all remember during COVID how much contact tracing, how important it was to control it. And I think right now it's also in 15 countries. So there, DRC it is spreading. And Mary's going to talk a little bit about what's going on in Kenya, but I'll pass it over. Thank you, Boniface, for all those insights. We're going to come back to you in a little bit. But Mary, we'd love to hear from you. You're based in Kenya, looking at what the communities are doing, and give me maybe a couple of examples of how the outbreak has affected Kenya.
Thank you so much, Bob. To start with, what we are seeing is that once a person has been confirmed to have Mpox, there is that isolation. And then their families are quarantined. So that therefore means then there is loss of livelihood. Their livelihood is affected. And then we are also seeing a lot of traffic in the health facilities anytime someone sees or suspects to be having symptoms related to Mpox. And that really burdens our health system, because they're already grappling with issues to do with the non-communicable diseases and the infectious diseases like malaria and HIV. And then, of course, the disease comes with an extra cost, because treatment and drugs, you have to buy that, and that is also putting a strain to the individuals and the local governments. Local governments, by putting up preventive measures to ensure that the disease doesn't spread, especially in those areas that are at high risk of getting high risk of Mpox. Then we've also seen a lot of misinformation. And there's a lot of, information passing through social media platforms. And this has really caused stigma and discrimination. And we are having those people suspected to be having Mpox being discriminated upon, and that affects also their mental health. This also happens when they're isolated, and we are really grappling with the challenge of getting them services to get mental health healthcare services, psychosocial support. So those are some of the key challenges we are facing in terms of this Mpox outbreak. Thank you. Over to you, Bob.
Yeah, could you maybe go in a little bit more into kind of how community health workers, or especially what their role is and how important their role is in the response? Maybe just to go a little deeper on that.
Now, from our previous experiences, especially in COVID-19 response, we really saw the need of engaging community health promoters. And what we are doing is active disease surveillance. And in this case, we are doing the community-based disease surveillance, where we engaged community health promoters in case finding for those cases that are suspected to be having Mpox, and then contact tracing. So you realize that most of the cases that have been reported are from long distance truck drivers, most of those confirmed cases. And so we do contact tracing when a case has been confirmed to identify those contacts that have been with these confirmed cases. And the community health promoters play a very critical role in this contact tracing. A case in point, we had one case in one of the counties, and through the community health promoters, we were able to do contact tracing and confirm another case that had been in contact with the case that had been identified before. So the community health promoters are really playing a critical role in ensuring that we have active disease surveillance at the community level, and also at our borders, our porous borders.
Thank
Over
you.
to you, Bob.
One more quick question. Going back to how it's affecting the other health systems, we saw a big effect of COVID on child immunization. So I'm sure that's something you're concerned about too, but also there is an Mpox vaccine, and maybe talk a little bit about where we are at. Do you have vaccines? Will you get them?
Now, we don't have vaccines at the moment, and what is happening, we are currently doing risk communication and community engagement just in case we receive the vaccines. From our experience in COVID-19 response, we realized it was important for us to create awareness so that we have the population ready in case we get the vaccines. And through that, what we are currently doing, we are engaging the trusted community members, like religious leaders, village elders, in creating awareness on prevention, and also in case there is availability of vaccination, on how to go about it. And then we are also making use of influencers in the social media platforms to create awareness on the same. So we are getting ourselves ready in case there is vaccination. Then we have a population that is already aware that in case they are vaccinated, they readily go for the vaccination for Mpox.
Yeah, this one where we've talked a lot about the community. How is Amref interacting with the Ministry of Health and other government entities?
Of course, from Amref for a long period of time has been at the front line when it comes to public health emergency. And from our record, you'll notice that during the COVID-19 pandemic, with our designs and approaches, we're able to vaccinate approximately 21.5 million people. So through our approaches in working closely with Ministry of Health, we are really working in ensuring that we train the healthcare workers that are actively engaged at the porous, at the point of entry. And we are doing this by ensuring that they receive training and the guidelines on Mpox screening, as well as PPEs, personal protective equipment. How should they don themselves when it comes to ensure that they do not spread infection at the facility and at the community level? We are also ensuring that we share information so that we all understand the different dynamics on how this Mpox is turning out. And we ensure that as we continually understand this Mpox outbreak, then we are able to tailor our approaches to respond to the different dynamics and responsive measures. Over
Thanks
to
so
you.
much, Mary. Maybe going a little bigger, larger picture, kind of continent-wide, Boniface, if you could talk a little bit how Amref is working with the Africa TC, also what kind of strategies are we looking at and implementing, and kind of if you could talk about that a little bit.
Okay.
I was actually passing along to Boniface.
Oh, thank you. Okay.
Okay. Yes, thanks, Bob. I think Mary had already indicated some of our interventions, but let me just summarize and maybe start by saying, I think one of the good things is the coordination that we have seen between the Africa Union and the World Health Organization in coordinating the response in the continent, but also globally. So because for the first time, I think what we didn't see in COVID, both agencies have come up with a joint response plan, which they lead and coordinate all of us to come through. And so as Amref, we have looked into the long list of the requests for support. I think there are over almost 10 or so pillars that they have identified: risk communication and engagement, surveillance, lab capacity, case management, infection prevention and control, vaccination, research, logistics, operations, but also just ensuring that there is a continuous delivery of the basic primary health care services. So as Amref, we have looked at our own niche areas, but also try to align as much as we can with the work that we do really in the public health space. And out of that long list, we have identified about 6 key areas of focus. The first one is the one that Mary just spoke about, which is community engagement, public awareness and education, normally known as risk communication and engagement. In this aspect, we are training, but also deploying community health workers together with influential leaders and ensuring that they raise awareness and ensuring that they provide facts, they dispel all the myths and misconceptions, they participate in contact tracing, and also linking all the cases to the healthcare system. And then strongly aligned to that is the whole, again, issue of community-based disease surveillance. As I said earlier on, one of the weakest points in our public health systems in the continent is this passive surveillance. But I think over the years, Amref has been able to build a model, test it, and also now expand it on how to use community-based capacity for surveillance. And in this case, we are using this by ensuring that our surveillance is what we call indicator-based surveillance, which looks at all unusual events in the communities that seem to have warnings on health. And so our community-based health workers are able to alert the formal system quickly if there is any unusual case. And in this case, with Mpox, once they see people presenting with symptoms, they are able to alert the system, leading to investigation, testing, and confirmation. Thirdly, as I said earlier on, we are really quite looking forward to support the lab capacity strengthening. And in this case, our lab experts in Amref are sitting in the technical working groups that are coordinated by both Africa CDC and WHO. And we are sitting there to help come up with proper guidance, tools and protocols on how to test for Mpox. So unless we get our diagnostics accurate, including the issue of genomic sequencing, as I said earlier on, that these clades, we have to know what kind of clade is manifesting where. And then fourthly, the issue of health workers is a strong pillar in any health system. And in Amref, this is our area that we have always focused on as our key pillar. And so we have two agencies in the organization that are really leading, working with our countries, of course, and other structures. The Institute of Capacity Building, which is a program in Amref, but also our international university. So they are putting together training packages with a view to increase knowledge, skills amongst health workers in different levels at community facility level, but also even at management to ensure that the Mpox response is appropriate. Fifthly, we are looking into the broader health system strengthening pillar and over and above deploying and adapting tools to address Mpox needs. We are also looking at issues of PPEs, personal protection for infection prevention control. And it's a clear ask from the ministries, the issues of mask, apron, sanitizers, and so forth, because if we don't prevent infection through the health systems, people will end up not showing up there. And we're also trying to ensure that our programs continue to support the delivery of services, even in the midst of the outbreak. And then finally, we, as Mary, I think Mary explained this strongly, the issue of advocacy for vaccines. We are readying ourselves, and I know that this week or early next week, the first consignment of vaccines, I think this is the Bavarian Nordic one, which will be in DR Congo, about 200,000 doses will be lent there. But we already, each country we are assisting each and every country now to put together a vaccination plan. These vaccination plans are really targeting what could be some areas at risk, population groups at risk, because the vaccines will not just be given everybody, but there needs to be a plan to target them. And this is where we're coming in strongly to assist ministries to have these vaccination plans. And Bob, as you earlier on said, we are already involved in another program in 22 countries in the continent, which is targeting integrated immunization. And what we are doing now, we are adapting those plans to ensure that Mpox vaccination is also in there. And this is then will be aligned to our community programs that Mary and other teams lead. Bob.
Yeah, maybe one other question, Mary, and I'll direct it to you, is I know there's a lot of the Africa CDC and Amref did a lot of work, and Boniface, you can also jump in, using digital technology. If you wouldn't mind, touch a little bit on how we use that and how Africa CDC to respond to COVID and how we're going to use it to respond to Mpox. You're on mute.
You're mute.
Come up again. I didn't get you, Bob.
I was just talking, I know during COVID, we used a lot of technology, digital technology to respond to COVID. And I'm just wondering how we're doing that and how the Africa CDC is using that for the Mpox response.
During COVID, we had a lot of electronic data-driven collection where we had real-time data being collected on COVID-19 cases. Those systems are already in place, so we want to layer on the existing systems on data collections to ensure that we get real-time data that will enable us to develop responsive preventive measures in a timely manner. So that is still in place. And then again, health system strengthening. We did a lot of training on infection prevention control during that time. And that is also meant to ensure that even during this time of Mpox outbreak, our healthcare workers are protected. We also provide, during that time, we provided enough, PPEs to the healthcare workers. So there is that knowledge that they know that they have to be adequately done, especially when they are testing for Mpox. So these are some of the lessons that we've learned during the implementation of COVID-19 response that we are going to layer on during Mpox response. Thank you. Boniface, would you like to add something?
Yes, just to also emphasize the use of basics, electronics or mobile, the mobile phone for surveillance. So our health workers, because they are networked in what we call the WhatsApp groups, for example, so they are able to alert each other on that platform, and eventually the leaders are able to then relay that into the national alert system, just if they identify cases. But more so, through our Institute of Capacity Development, we are already finalizing sort of a basic course on Mpox management, but this entails largely case management, infection prevention and control, and this is online in a platform that we call LEAP, which we have tested over many years for different responses, and we look forward to launch it next week, so that it's available for healthcare workers who can have access on these online tools just to empower themselves with accurate knowledge. We are also trying to liaise with UNICEF on the issue of contact tracing, because that's where, again, we find a severe, a huge gap in terms of capacity. How can community health workers who are involved in contact tracing by following used gadgets and technology better? And I know in South Sudan, again, maybe even in Uganda, our teams are trying to work out with the ministries on how can they enhance information sharing, especially for cross-border surveillance. And again, we are trying to figure around what will be the best tools that can be used to ensure that countries share information about people who frequently cross borders in different countries. Well,
thank you, Boniface. Thank you, Mary. So I think we're going to get ready to go into allowing folks to ask some questions, but just kind of a little process. Obviously, this is a supporter call, and I think there's a lot of ways folks can help. And I think Boniface kind of broke down the 5 or 6 different ways that we could help. And we definitely need investment, early on investment, obviously, especially will be our focus will be community disease surveillance. So we'll be sending kind of a concept note with those 5 points and just a little more detail. So you can, if you're interested and there's a way you can help out, we'll give you that avenue and we'll follow up with that. So we'll send that out early next week, but pass it along to Jenny or I'm sorry, Erin, and you can take some questions and answers, give some answers.
Great. So if anyone has a question, you can go ahead and pop it in the chat. And if not, then you can also just unmute yourself at this time and ask it. So I'll give a minute or so if anyone wants to unmute themselves and ask a question.
Okay, no questions. So we either did a very good job communicating. Okay, we have one question.
Hi, everyone. My name is Latifa Mosley. I sit on the Associate Board of Director for Amref. Thank you so much, Boniface and Mary, for your presentation. I wanted to know more about, you all talked about a lot of things and to do with, kind of preventing more of the facility-based infections. Are you all doing anything in regards to holding unit at these facilities? I know that was used a lot during the Ebola outbreak. So could you speak on that, or is that something that is being focused on at this time? Thank you.
Mary or Boniface?
Mary, do you want to start? My audio was not very audible. I sort of bumping. I could feel it was around. Is it around infection prevention and control, or?
Yes, I'm not sure if you're familiar with like the holding units that were developed at many of the health facilities during the Ebola outbreak. I know I saw that, you all were working in Nimule for the current Mpox outbreak, and I actually was there during the Ebola outbreak. And what we did a lot at the health facilities, we built holding units. I'm wondering, is that a strategy being used at this time for the Mpox outbreak? Thank you.
Yes, yes, the mechanism and the practice is largely the same, because if you look at the spread patterns of both diseases, be it Ebola and Mpox, it's almost similar. And as you rightfully say, one of the critical elements is really ensuring isolation of confirmed cases. And this is one of the gap areas that we are seeing, and we are receiving reports, particularly in DR Congo, where the health facilities are severely constrained to provide the most appropriate isolation units. And as such, then people are sort of, even if they are really not severely sick, to be transported to better equipped facilities, they are sent back home. And through that process, and we all understand, most of our communities in that kind of areas, the isolation is really like a luxury. To get an infected person to completely isolate by receiving the appropriate care. So the practice is the same, in short, but there are severe limitations. And that's why the Africa CDC and WHO are also calling on partners to support with use of case management, and particularly to strengthen isolation and ensuring that patients recover in the most appropriate conditions. But again, one of the critical elements that we say is the whole issue of protecting our healthcare workers. And that's why even the first batch of vaccines that will come, again, over and above people with underlying conditions, health workers will be the first ones to receive these vaccines to protect them. But PPEs, again, are critical to ensure that our health workers are protected. As you rightfully say, even use of ensuring that there's proper sanitation and hygiene practice. Running water is a luxury in most of these, and I think most of you will know the situation in Goma in DR Congo East, where there's a conflict and so much mass movement of displacement of people. It's very, very difficult to provide appropriate care in those circumstances. I don't know, Mary, whether you want to add anything at this point.
Thank you for that. That's so pivotal in the support that is provided to Amref in ensuring PPE and other supplies to carry out this work. Also wanting to know how maybe what are you all's concerns in regards to some of the stigma that is attached to the Mpox, prior to receiving the vaccine. I know that you already mentioned some of your risk communication and community engagement activities, but what are you seeing on the ground in regards to stigma to these large numbers of population in specific areas that currently have Mpox?
What we are currently seeing is that where we've had cases reported on Mpox, the families are being sidelined. And, we are a social community. So once we start sidelining, then it means then they cannot attend social events, they cannot go to work, and they cannot also participate in other community events. That's the key thing we are seeing. And that also means they cannot go to the market, they cannot go to church, and that's very important for the communities here. So those are some of the issues we are seeing, and it goes even beyond, even in schools, when students learn that the family has been affected by Mpox, there is that, being sidelined and all that. So those are some of the cases that we are seeing, scenarios we are seeing currently when it comes to stigma.
Thank you, Mary. I think we have a couple questions on testing. I think Mercy asked a question of why are the minimal numbers of Mpox of suspects being tested? And is it a matter of resources? And then there was a follow-up question along that is, how much does it cost per person to test?
Do you want to start, Mary? Yes, go ahead.
I can start, then you come in. What we are seeing in Kenya is that the turnaround time is between 5 to 8 hours, and that's a long time to wait for a test to be confirmed. And that means we have a long waiting list, waiting for that confirmation. And currently, as we speak, testing in Kenya is free, and maybe Boniface would enlighten us on how much it costs in these other countries. Boniface, over to you.
Yeah, sorry, I will apologize, but we can find the figure and share it. The actual, I don't want to really throw in an unconfirmed amount, but testing, as we know, is a sort of a process which begins all the way from sample collection. And one of the challenges we are seeing, and is especially in those areas where the testing facilities are a bit of a distance. We are told in DR Congo it takes about 2 days for a sample to move from the on-site just to get to the testing facility, the designated centers. So you can imagine the issue of one, transportation of that sample, the quality gets compromised. And we have heard and we know that most of the negative results are really not based, are really due to a test of the compromised kind of sample. And that's one of the things that both Africa CDC and WHO have highlighted, the issue of distances. There are very few labs in most countries. Just yesterday, I was in a meeting, Ethiopia with that huge population and that vast country. And we only know that currently there are just about 14, the whole country, designated places where samples can be tested. So you can imagine in Burundi, DR Congo, it's even worse. So that's one of the issues that limit the access to testing. But we'll have to pick out the exact cost of the test. Over.
Yeah, Mary, during COVID, was Amref were our labs doing testing for COVID, and are we planning on doing that for Mpox?
Yes, Amref was doing testing for COVID during that time. We are currently trying to source for funds to enable us equip fully and strengthen our lab diagnostic equipment to enable us test also for Mpox. So that's something we are looking forward to. And our labs are working closely with the Global Health Security to see how best we can go about it.
Thank you.
Okay.
We still have about 10 minutes. So anyone has any other questions? We have a question. Are rapid tests available or forthcoming? I don't know if there are. Go ahead, Boniface.
Yeah, yes. And unfortunately, there's been a lot of debate, and that's where our lab team is currently participating to discuss the issue of rapid testing. So far, we have told that there have not been really specific tests which are sensitive enough to be deployed, but that's an area I think that both WHO and the manufacturers are looking at. So for now, it's really PCR test, which we test, which are being deployed. As Amref, we are supporting, and in most cases, people have to use the GeneXpect machines, which largely are designed to test other things, but we have to buy cartridges now, which can be used for, because the GeneXpects tend to be largely available. But again, we've been told that the accuracy of those tests is between 67 and 72%, meaning that there could be almost 30% cases, which again, the current PCR tests could miss out. It's either you get false positives or false negatives. And that's an area that is really urgently being addressed to see if there could be a rapid test that can be deployed efficiently. And even the GeneXpects, I think there are still issues, even of quality control. And Amref is supporting the training of lab experts in 12 countries. That training should happen in the next 2 weeks. where the focus is really on interpretation of some of the test results, but also issue of sample collection and management. Those are critical gaps that also need to be addressed. Thank you.
Okay, another question, is Amref focused in DRC or also on neighboring countries like Rwanda? And how effective is the vaccine? I'll let you do this because maybe talk a little. Go ahead, Boniface, you can answer this question, please.
Yes, as I said, currently we are involved in 2 levels in DRC. One is the supply of cartridges for the GeneXpert testing machines. We have I think the shipment should be in DRC early next week. The order has been confirmed. But as I said, again, we are also supporting the training of about 122 lab experts, which will be trained in batches in countries around Central African Republic, Rwanda, Uganda, DR Congo, again focused on testing. That's how we are involved at the moment in those countries, partnering Africa CDC and the WHO and our other partners on the ground. Thank you.
Yeah, I mean, I think Amref works kind of on 2 levels. One is the strategic level and kind of helping provide technical assistance across, not just in the 15 current countries where there's Mpox outbreak, but also in the preparation of for the next steps. Like during COVID, we were part of a consortium, or we led a consortium that worked in all 45 countries in Eastern, Southern, and Western Africa. So we're doing that. But then like in Kenya, as Mary was getting very detailed, we're on the ground working with our partners there. So kind of 2 levels. Someone asked specifically about Rwanda. I don't know if you have an answer to that, what we're doing in Rwanda, or if we're doing anything in Rwanda. Boniface.
Oh, sorry, Bob. I thought that was a comment. Sorry, I missed it. Can you just...
No, someone asked specifically whether we were doing any work in Rwanda or neighboring countries. I know we're doing in neighboring countries, but I don't know about Rwanda.
Oh, okay. Yes, we other than just Mpox, we are working in Rwanda to support the integrated immunization, as I said. So Rwanda is part of the 22 countries that we are supporting under the Africa CDC coordinated program. As I said, in DRC, we are currently just responding to support the responders from Africa CDC who are on the ground. So yes, that's how we are involved there. But what we are doing in our team in Uganda is we are trying to strengthen the surveillance along the border with both Rwanda and also with the DR Congo by using community health workers on the ground and health promoters, just so that we are able to support that initiative of case finding and so forth. So yeah, that's what we do. But obviously the guidelines, the tools that we develop and deploy through Africa CDC are used even beyond where we have the physical presence, as you rightfully say, through technical assistance.
Okay. Another question about public awareness and how the media's respond or using mass media to respond to the Mpox, and how is local media reporting about Mpox?
The situation in DR Congo is a bit complicated, especially given that the epicenter, I think there's an area it's called East Kivu, if I'm pronouncing that correctly. And this is an area, again, with Goma, where we know there's this whole crisis of the ongoing fighting, the mass the movement of people. So really issues like local media are a luxury in those places. Yesterday, I was in a call with one agency which is on the ground, and they were trying to say they're trying to use the networks for sex workers to see if they can get them to spread the word. But the limitations was the issue of reach through mass media. In most cases, they are forced to use peer-to-peer engagement. It's difficult even to organize some of these mass public awareness education. It's not easy to bring people together and start giving them those public lectures on the ground. So it's a complicated situation, which we are also still trying to understand. And unfortunately, again, as Amref, at the moment, we are not supporting directly the community engagement risk communication directly except through other agencies. So it's still an area that needs to be fully looked at and understood. But what we are getting from partners, Africa CDC, it's a situation which needs a whole lot of assistance in different forms.
Thank you, Boniface. I'm sorry, Michelle, I didn't realize you had your hand raised. Would love to have you ask a question.
Sure, thank you for that. My name is Michelle Merkel. I'm from Global Scientific Solutions for Health, and we support different laboratories in different countries for health system strengthening. So I very much appreciated the conversation on diagnostics especially, and thank you for this information. And my question is, for any labs or facilities that are considering taking up testing, what kinds of considerations should they have on the management side, the treatment side, to make sure that there's kind of, that care piece is also considered as, if someone's being tested? Thank you.
Yeah, again, the protocol is always that you test and then confirm, and then it must lead to access to care and treatment. That's the standard protocol that we use in these scenarios. But as we have been saying, I think Mary at some point alluded to the issue of stigma. What we have seen is that most of the cases have been driven underground because of fear of being stigmatized, being criminalized for being the host or the spread of this infection. So that underlines again the issue of really unraveling all these myths and misconceptions. But again, if you look at the current limitations in testing, it means a lot of people who are supposed to be tested, confirmed, and then put through to appropriate care. That's a missed opportunity. It's a huge limitation. And Africa CDC and WHO have really called out to say, the issue of testing is critical, but again, even access to therapeutics themselves. I spoke about tecovirimat as one of the therapeutics that is being used currently, and it's not a cheap drug, as all you know. I don't have the figures of what it costs, but it's sort of, I even saw here in South Africa, which is quite a very able country, but I heard the minister the other day saying they are looking forward to get assistance to bring as much treatment therapeutics into the countries as possible. So then you wonder countries who are far worse off than South Africa in terms of access to these therapeutics, which could really help to manage cases. So it's an issue of again of a big need, case management, diagnostics, care. It's just a chain of this need. Thank you.
Thank you, Boniface. I think that is our lab. We have one more minute. I want to hand it over to Jenny to thank everyone.
Yeah, this was an amazing conversation. Boniface and Mary, I really appreciate your time and all of the information you have shared with all of us. Thank you all for asking such wonderful and thoughtful questions. We will be sending the recording out next week, early next week. And I wish you guys all a wonderful week ahead of you, weekend. And thanks again for attending one of our supportive calls.
Thank you.
Thank you. Thank you for having us.
Bye.
Thank you. Bye.